Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
I am super excited to introduce today's guest, Dr. Dayan Goodenowe. Dr. Goodenowe is a PhD neuroscientist, a synthetic organic chemist, and a biochemist. He's one of the smartest guys I've had the opportunity to sit down and have a conversation with, and he is going to talk in today's episode about plasmallogens, a type of testing that he developed for metabolites, and the overall disease process in human physiology as plasmallogens play such a huge role. This interview went a little long because of the depth of content, and for that reason I've decided to break it into two parts. The second episode, which will air next week, will deal more with my individual testing, where we go over what my prodrome scan showed and how I can maximize my health by doing the things that were recommended by him for this testing result. So without any further introduction, I'd like to introduce my guest, Dr. Dayan Goodenowe. All right, I'm here with Dr. Dayan Goodenowe, and he has authored the textbook that's in your screen here, Rethinking Alzheimer's, a 15-year crusade to expose the cause and deliver the cure. I was first introduced to your work by a mutual friend and colleague, Maria Watson, and then got into some of your writing and everything. And I as soon as I read this book that you wrote on Alzheimer's, I said, I have to get you on. I have a very personal interest in Alzheimer's disease because my mother unfortunately succumbed to the sequela of Alzheimer's. And so prior to her passing, I was very interested in Alzheimer's. And so thank you for joining me, Dr. Goodenowe. And I hope that the audience finds you as interesting as I do, because I know it'll be a fantastic interview.
Well, thanks so much, Stephen. I'm so happy to be here. And like I said, we'll happy to discuss any of these topics, because there's a lot of knowledge out there. And one of our challenges is really not collecting more of it, but start to implementing the knowledge that we already have. Is one of our biggest challenges.
So your background is a neuroscientist, a synthetic organic chemist, and a biochemist. And one of the things that I was very interested in was your development of the technology to look at all of these different metabolites. Can you tell the audience a little bit about that?
Yeah, so like I said, my background is in the biochemical mechanisms of psychiatric diseases, and that's then progressed into other disease areas for sure. But my background is in chemistry and synthetic organic chemistry as well, and the whole area of biochemistry. So back in the 90s, when this whole genomics revolution was taking off, when we were sequencing the entire genomes of species, and we had the ability to identify these gene sequences, but we didn't know what these genes did, right? So we had this initial phase of massive genetic knowledge in terms of the transcript of how genes are being transcribed and expressed, and what's controlling that genetic expression, and what does that genetic expression mean. And nowadays, a lot of people are thinking about the epigenetics and of the methylation of the genome. But back then, this whole concept, it really changed mentally science in a way that most people don't really recognize the transformative nature of it. prior to that genomics revolution, most of science was really hypothesis testing, is that you would pre-think a hypothesis, and then you design an experiment to test that hypothesis, basically try to make it fail, right?
Right.
And then if it doesn't fail, you have to accept it until you can make it fail. But what happened with this big data concept is that people started saying, you know what, let's just generate the data first, and we'll see if we can, identify what's coming out afterwards. So it became, rather than hypothesis testing, it became hypothesis generating. And this was capable because we could measure large amounts of information at once with the genomics. What wasn't capable at the time was the ability to simultaneously measure the small molecules, all your metabolites, and all of because we're biochemical in nature, right? We don't take sunlight and water to survive. We need to ingest carbohydrates and proteins and nutrients, and our body transforms these things into the living, being that we see in front of us. And that's a very complex but very integrated system. And there was no way of really measuring that. And so I, expert in mass spectrometry and developing these advanced technologies, started really focusing on how do we measure everything. And I eventually came up with a concept, a technology called non-targeted metabolite profiling, using high field magnetic resonance imaging. So we used an ion cyclotron to use very high resolution. And this allowed us to measure thousands and thousands of small molecules, but with a sufficient accuracy and resolution that we could determine the molecular formulas without any prior knowledge. Sorry, this is a big, long explanation. But So now that changed the whole world, because now I didn't have to look for homocysteine. I didn't have to look for cholesterol. I didn't have to think in advance and develop a single test for a single molecule. I could measure everything at once. And then I can ask the question, by people with Alzheimer's and people without Alzheimer's, what is the biochemical difference? How is the body biochemically adapting to this disease state, whether it's colon cancer or Alzheimer's or autism? And the question at first was saying, if there is a physiological disease state that you can clinically see in front of you, okay, there must be a biochemical correlate of that, okay, because that's who we are. And the answer to that question is 100% true. The diagnostic capability of it is very earth-shattering. And that was really designed to look at as saying, can we identify people with disease, and can we identify people early with disease? And what happened was, first of all, that was doable, and it's very, very powerful at doing that. But when we started looking at longitudinal aspects of disease, like colon cancer, after colon cancer removal, when people were technically cured or they were disease-free, if you will, what we found was that a lot of the biochemical changes were not going back to normal. They were staying the same as they were. And this indicated that what we're measuring is the prodrome of these diseases. We're measuring the people that get the disease. We're not actually measuring the disease. We're measuring the people who get disease. Mm-hmm. And so that was the whole flat tire versus bald tire scenario. So we actually found out we were actually measuring bald tires before they got flat. And this really changed the whole mindset of causation of disease, as well as prevention and intervention of diseases, in the sense that we can now restore normality independent of disease. So diseases create their own symptoms, but we treat those symptoms for improved quality of life to a certain degree, but those treatment of symptoms, as many of your listeners will know, don't deal with the underlying causation. And so what this technology was really driving was this underlying causation of why, one sister gets ovarian cancer and the other sister doesn't. Right. And that's kind of where that came from. So that's where the technology comes from. And so it's really the core, not only of the diagnostic interpretation, but it's really the core of changing how we think about human physiology over the course of time. And so it changes our thought process to, rather than looking for disease, we look for deviations from health. Okay. Right? Because we can actually, and it flips the script in a sense that rather than looking for a symptomatic disease cascade is that, you know what, we know what normal is, right? We have thousands and thousands and thousands of normals. Because every time we run a disease on Parkinson's or multiple sclerosis or colon cancer, there's always going to be a disease-free cohort, right? And that doesn't mean the disease-free cohort still have people with risk in it, but fundamentally they're different. And so we actually know what normal is. We actually know what the normal, healthy, functioning human body should do, how it should function, how it should perform. So that's not up for question anymore. So I don't really need to wait for disease now. I said, if this is how the operational parameters are supposed to be performing, then I just have to wait. I just have to measure deviations from that. And then I can link those deviations from when oil in your car gets below the dipstick, okay, what are the likely predicted outcomes if that is left for too long?
Right.
Okay. And so I don't have, but it's not, your engine's not going to seize the next day because you're a little bit low on oil. Okay. But if you're low on oil for a long time, yes, it will. So the question is can low oil be predictive of a future event? And the low oil in your engine crankcase is basically a prodrome. And what it is, it's a deviation from the normal operating condition. And so the current way we typically do things, you have a car with a seized engine, and you go, wow, man, goodness, this car is all seized up. Wonder what caused it. And then you look into it, you open the engine up, and you say, oh my goodness, it had no oil in it. Okay, so you're looking for the lack of oil after the symptoms. But in fact, you can be low on oil and the engine can still be running properly for now. And that's where this bald tire, just because you have a bald tire doesn't mean you have a flat tire. And what we do in the medical industry a lot is that we take that bald tire that got a nail and got flat, we just basically patch the hole and put the bald tire back on the road again, which is why the recurrence of disease in a particular population is always higher than people who are completely naive of that disease. So if you were diagnosed with colon cancer at one time in your life, you will have a higher risk of colon cancer than someone who never ever got diagnosed with colon cancer, and so on and so forth. And so and it's really quite logical once you start. It makes just complete sense. Rather than chasing our tail all day long after one symptom after another, it's really just saying, let's focus on what health is. And that's when, the Breaking Alzheimer's process and concept came up, because this technology diagnosed these low levels of plasmallogens, and that the level of plasmallogens in the blood correlated with the rate of cognitive decline, correlated with the severity of cognitive decline. It virtually, reduced the age association with dementia because age is associated with plasmallogen deficiencies and so on and so forth. So it actually allows us to understand some of these variables that we associate. For example, people think, okay, my risk of colon cancer goes up as I get older, which is why we do colon cancer screening with people over age 50. Well, it's not age that makes you higher risk for colon cancer. It's the loss of certain gut anti-inflammatory metabolites called gastrointestinal tract acids, GTAs. And if you correct for the GTA levels, an 80-year-old with good GTAs has the same risk of colon cancer as a regular 40-year-old. So your age association disappears completely, because age is actually a biomarker of GTA deficiency. So as you get older, more people become GTA deficient. So we start looking at these known associations with disease, and we can start actually understanding what is the meaning behind them using this kind of technology. And just so it opens up a whole new way of looking at things. And it also changes the way we implement medicine, because the system is not, we have a symptomatic based symptom, which actually has worked very, very well in the acute care system, right? Like if you get a broken leg, you get in a car accident, you're far more likely to survive now than you ever were in your lifetime. So we have really good acute care medicine, and it's been systematically better and better at it. But chronic care is not about fixing a negative. It's about maintaining a positive. And I think this is what we do a lot. We think that if we remove all the negatives of an environment, if I remove all the nails off the road, I'll never get a flat tire. Well, it's not possible, right? So at some point in time, you have to say, you know what, I have to retread the tires. There's just a limit to what just eliminating negatives can only get you so far. We have to restore the positives in human physiology. And that's what's missing in longevity research, is that we think that if we prevent or we reduce premature death, that we're going to live longer. And that's not true. What happens is we just all end up dying at the same time. Okay. You know what I mean? Like, right. So it's and that's actually just statistically and very observable. Like people, like we don't live longer. We just don't die earlier anymore. Okay. Yeah. So anyways, that's a long diatribe. So simple question. I keep on like.
No, I think it was great. Me in. That I just want to unpack that just a little bit. So, one of the things that you point out very well in your instructional courses is that just because you have a genotype doesn't mean that you're going to manifest necessarily a bad phenotype. And we can get to that when we talk about Alzheimer's specifically with the ApoE4 versus an ApoE3, that type of thing. But before we get to that, I think we should talk about what a plasmallogen is, because most people don't know that.
Yeah, it's really quite shocking not to know what plasmallogens are. We've known about them for years and years and years. I think they're first discovered in the 1920s, for example. And we know the severity of plasmallogen deficiencies. Okay, like there are rare diseases in children that are born with a genetic mutation that prevents the manufacture of plasmallogens in your body. These children die very young and with severe neurological and skeletal deformations. Okay, So plasmallogens, in terms of human physiology and their importance, is not a new thing, but they've been taken for granted. So plasmallogens are a phospholipid. They're called an ether lipid. Now, and these are the building blocks of your biological membranes. And so if you think of the human body like a massive apartment complex, the compartmentalization of the human body is performed using biological membranes. And that's how we make walls, essentially. Right. That's how your heart is separated from your brain. That's how inside your cells, you have an outer cell membrane, and inside you have your mitochondria, you have peroxisomes, you have your Golgi apparatus, your nucleus. So all this compartmentalization that occurs in the human body is done using biological membranes, and like the walls in a massive apartment complex, and allows us to do certain functions in your kitchen without making your bedroom smell like fried onions. Okay, so you can do things in different areas of your house, and your body is organized the same way. The building material that your body uses to make these membranes are called phospholipids. And these phospholipids create basically a bilayer. They're like soap. And they have like oil and water, if you will, like you blend a salad dressing up. And it has a fatty side chain called your fatty acids. And then you have a polar head group that likes to be in water. And then the fatty acids self-organize in the center, and they create this lipid bilayer. And basically, it's an impervious wall. And your body has various levels of different types of phospholipids. People hear about phosphatidylcholine, for example, phosphatidylethanol. Plasmallogens are a type of, the main groups are the phosphatidylethanolamines. There are ethanolamine plasmallogens. And in phosphatidylcholines, there are choline plasmallogens. And you have lots of them. Over 50% of your heart lipids are plasmallogen, a very, very high amount. And it's and very high amounts in your brain, like 75% of the synapse for neurotransmitter release will be plasmallogen. The myelin sheath that protects your axons, both in your brain and on your periphery, extremely high levels of plasmallogen. And what makes them unique is that your body makes them. But the last step in their manufacture creates a special bond called a vinyl ether bond. And that's what gives it its special physiological usage. But it's also its Achilles heel, because that vinyl ether bond is the main neutralizer of peroxide in your body. More than all of your glutathione, more than all of your catalase, more than all of that stuff. When it comes to an inflammatory stress event, plasmallogens, pound for pound, neutralize more reactive oxygen species than anything else in your body, because your body has a whole bunch of it, and it pumps it onto it like a fire truck pumps water on a flame. So, but we take it for granted because your body typically makes more than enough of it, right? We have for most of our life, we have a really good manufacturing capacity for plasmallogens. And so they kind of say, well, it's like water, like I don't have to worry about it. Like, yeah, it's always there. But it's not always there. And so these plasmallogens, so this vinyl ether bond that gives them the special capability makes them dietarily unavailable in the world, because when you eat a nice juicy steak or you take, an animal product that'll have plasmallogens in it, as soon as it hits the hydrochloric acid in your stomach, they burst apart and they can't get absorbed. Okay. And that's why your body is not dependent on the environment, because plasmallogens are so important in the human body that it will not allow itself to rely on nutritional sources. However, that is also its weakness. So later on in life, when you can't make enough of it, there's no dietary source of them other than breast milk, which is there for kids. And then there's some like shark liver oils, which will have other issues with them. But there's really rare, relatively small availability of these plasmallogens. And the dietary version is a precursor. It's like a lot of other vitamins. Like when you take vitamin B3, for example, niacin, right? You're not taking NAD. You're taking niacin. Your body converts niacin into NAD. So a lot of what we call vitamins, right? They're actually precursors of the actual vitamins that your cells use. And so same thing with plasmallogens. The dietary source that the body can use are actually precursors. And so in human breast milk, you have what's called alkyl glycerols. And that's a precursor, and specifically the structure that your brain myelin uses for white matter development. And so that's kind of how it goes. So that's what plasmallogens do. And they have 4 core functions in the human body. One is this myelin sheath. They create this very, very protective coating that allows the axonal transmission. So for neuropathy and things like that, any kind of multiple sclerosis, ALS, concussions, all that white matter diseases, inflammation of the brain, that it really affects that myelin first and foremost. And so plasmallogens are like 70% or more of the ethanolamines in your myelin sheath. So that's one area. The second area is nerve transmission, like the synaptic release of neurotransmitters.
Right.
Okay, so the other thing about human physiology is that because the body has to use biological material to do the same things that we take for granted in our everyday life, right? So when you flip the light switch on your wall, okay, electricity goes through the wire, all the way through the wire to your light bulb, but the wire has connections, right? There's long distances where it's just one wire with one coating. It's all the same for the big, long distance. But at some point, that wire has to connect to another wire, and that's a switch, right? And so and that switch can be turned off and turned on, and it can be gated, right? You can be a high signal or a low signal. Like you can have a dimmer switch, for example.
Right.
But the human body has to do that with biological material. And how the human body does that is called vesicular release of neurotransmitters. So what it does is that the presynaptic neuron contains neurotransmitters in a little bubble called a vesicle. And when you turn the light switch on, the vesicles fuse to the membrane, and then they release their neurotransmitters into this little cleft, and then they connect to the next neuron, and that's how the connection is made, and that's how the communication is going. And you can think of it like a shower head in your shower, right? Like you get one of those showers that have like 100 different little outlets, and if you just kind of turn the water on and off, on and off, on and off, and you get this pulsing, that's basically how synapse works. But in order for that bubble, that vesicle, to fuse with the membrane, it has to have a high level of plasmallogen, like 75% plasmallogen. Otherwise, the bubble will hit the membrane and just stick there. It won't actually fuse and release its neurotransmitters. So when we look at post-mortem brain analysis and we look at cognitive functioning, that's why these omega-3 plasmallogens, the DHA, have a very, very strong correlation with cognitive function in the brain. So number 2 on the plasmallogen top 4 list is this vesicular release of neurotransmitters in the synapse. And it's not just the brain, it's your neuromuscular junction. And so most people don't realize that dementia highly correlated with sarcopenia. So muscle loss and dementia go hand in hand. And that's why resistance training, skeletal muscle mass improvement in the elderly is one of the most powerful preventers of not only type 2 diabetes, but also of Alzheimer's, because your skeletal muscle mass and the neuromuscular junction is really critically important. So that's number 2.
Okay.
Third part is membrane structure. Like, so these membranes have walls and windows and, things have to move in and out of the compartments. And one of the main regulators of all of our cells is cholesterol regulation. Okay. Cholesterol is arguably the most important lipid in the human body. Okay. Almost 50% of your outer membranes are cholesterol. Like, cholesterol is really critically important. And your body has so many different mechanisms to control and transport cholesterol levels. And the ability to get cholesterol and regulate cholesterol in and out of the membranes is highly, highly correlated with the plasmallogen composition. And when plasmallogen levels get low, the membrane levels can get elevated. And cholesterol gives membranes their structural rigidity. And so if you get too much cholesterol in your membranes, they become rigid and things can't move in and out properly. And one of those things is cholesterol transport and HDL system. So plasmallogens are really critically. So atherosclerosis, when you want to get rid of cholesterol out of the foamy macrophages, for example, when you have that leukocyte infiltration of the endothelial layer, for example, that plasmallogens really suck that down. So we can lower C-reactive protein in 24 hours with plasmallogens. If you take a high dose, like seriously, 24 hours, you can drop your C-reactive protein in more than half. Just by one high dose of plasmallogens. Like, it just totally neutralizes that kind of stuff. And then the final, and probably continually another main one, is actually pure antioxidant capacity. You can think of, and so your membranes have structure, but they're also big reservoirs. Like, you don't have all these lipids and things just floating around. Like, your body actually stores them. It's kind of like it's like using the entire shell of your Tesla as a battery, for example, right? Like, it's actually storing, or you have it's the whole car becomes your charger, for example. Your body's membranes are not just there for show. They actually are a huge reservoir of bioactive molecules. They're just sitting there and storing. And you can think of it like having a lake reservoir next to a small town, right? And what happens is if there's a fire in the town, the fire trucks come, they pull the hose into the lake, and they start dousing the fire with the water from the lake. Okay? And as long as they get the fire out without draining the lake, you're okay. Now, the lake will have some sort of feeder system, right? Maybe there's some stream coming in from the mountains, and it has a certain rate. Okay, and so you get the fire out, and then, okay, give yourself time. Gradually, that lake will build up as reservoir again. That lake is like plasmallogen. So in your heart, when you have myocarditis, or if you have ischemia, like you have any kind of inflammation of the heart just pumps plasmallogens out of its membranes like crazy, and it does it to douse the inflammation. And so when you have people with COVID and they're having these myocarditis issues and lung and heart issues, it's because this long COVID that they've been suffering has drained their tanks. And they're now stuck with an empty lake, and the only amount they get is whatever's trickling down. So whatever is trickling down is all they got. And so when we give people like that high doses of plasmallogens, we pull them out of ICUs in 24 hours. They go off their ventilators, their lung oxygenations come up, their bilirubins come back down. It's pretty crazy. So what we can do is we can basically drop ship. It's like bringing tanker trucks of water in, and we're secondarily filling up that tank. So that's the 4. Plasmallogens are one of the only true neutralizers of reactive species, because that vinyl ether bond is like a fuse. Okay. It reacts with peroxide, completely neutralizes it, but it gets used up in the process. It blows up. Okay. Which is fine. So it's like cannon fodder. It's like the first round of soldiers going to the war. The body just sends them out there. Says, okay, go ahead, destroy yourselves, and one for one, So one plasmallogen molecule will neutralize 2 hydrogen peroxides into complete neutralized molecules. So that's the 4 things about plasmallogen. And that's why it has such a huge association with, there's certain core components, like you'll see Alzheimer's, you'll see, certain cancers, but the all-cause mortality is pretty scary. Like there's a 30-year differential in your lifespan based upon your plasmallogen levels in your blood.
Yeah, I saw that in your master class where you talked about the sweet spot of cholesterol being between 220 and 240. And it was amazing if you looked at all your different age groups that you had delineated in those graphs. If you were in that area as a 65-year-old versus a 95-year-old, your mortality was pretty much the same based on that cholesterol level. That's a huge finding.
Yeah, and I think it's when we start looking at health in a different way. Another one people forget about, like creatine. There's another big, simple, cheap metabolite. It's such the body, the amount of energy your body needs to make creatine every day. It's responsible for 40% of your homocysteine load, for crying out loud. Or uric acid. People, we don't want high uric acid. Fine, if it gets way up there for gout, but really low uric acid indicates an NAD deficiency. And so we have a lot of these things that we have developed for acute care, right? Remember, medicine fundamentally has been developed from sickness. A patient comes in, they're already sick, right? Your job is to find out what's making them sick. And is it going to kill him in the next 24 hours or not? And if it is, what the hell do I do to keep this guy alive? So it's disease is presupposed in the current medical process because that's what it's been built from. And so we've developed lots of good technologies, right? So yeah, I want to know that uric acid is through the roof. Okay, it could be kidney function, or creatinine is at 3 or 4 or 5, or these other molecules that are really good acute markers. But that isn't the same as, longevity. When we're saying, okay, we're not talking about now acute disease indications. So low uric acid is actually far more dangerous to you long term. In fact, people who suffer from gout have higher intelligence than non-gout sufferers. Okay, so high uric acid is associated with higher cognitive functioning. Unfortunately, it has a negative consequence with with fatty liver disease and cardiovascular outcomes, which are all valid. So there's sweet spots, right? So you want your uric acid between 5 and 6, for example. You need to get your creatinine over 1. If it gets muscle wasting is a big deal. So I think when we start looking at these, what is a healthy level? Like cholesterol level, right? It's a sweet spot, and it means something. Like if your cholesterol level gets under 200, it means that your cellular integrity is poor. It means that your cells can't make enough cholesterol for whatever reason. The cellular energy capacity. Those cells are sick. They're weak. They're not making enough cholesterol that they can share with other systems. And so when you start looking at what the healthy body is how it's supposed to function, we have all this data. We have all this all-cause mortality data. It's all over the place. Really good studies. And then so we know what health is. We actually know what these numbers should be. And if they're not where they are, then we have to ask ourselves why. What is it behind the curtain? Okay, so now we can say, what's operating at suboptimal functionality? Is it my mitochondria? Is it my peroxisomes? Is it nutrition? Am I missing something? And so now we can use these deviations from health in a much more inductively reasoned way. We say, okay, how can I understand? Because what I'm seeing in front of me isn't random. The human body is adapting to its environment. It's telling me, and so now we just need to connect the dots behind the curtain as to why the human body has decided that this is the best scenario for it under these certain circumstances.
All of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
So anyway.
No, I think that was excellent. I mean, excellent description of what these molecules do. And, the one question that I've had actually when I first started really diving into the Alzheimer's literature 4 or 5 years ago, was that like the all-cause mortality, you had a better chance if your cholesterol was above 200, 210 in some of the literature that I saw. And it just makes sense when you added on to what you just said about membrane integrity and how much the brain is really cholesterol. And then you have the other parts of mainstream medicine that are constantly trying to press that down. Everybody's on a statin, got to get that cholesterol really, really low. I mean, that's the cardiology dream, right? And not the functional cardiologist, but mainstream, I would say, they don't want that above 200. And they're, trying to manipulate that when I think it's really how much of it's oxidized, how much of it is inflammatory. Is that correct, or am I on?
That's 100% correct. So it's a classic scenario of throwing the baby out with the bathwater, so to speak. It's really quite that scenario. So lowering cholesterol. And so remember, when we're talking about lowering cholesterol, people are talking about lowering LDL cholesterol, right? And the problem with atherosclerosis and cardiovascular outcomes is oxidized LDL that infiltrate the endothelial layer. Okay, you get inflammation in the lining, right? And it causes swelling. And that inflammatory component comes from this leukocyte LDL infiltration through the endothelial layer, and it's oxidized LDL. And that's a bad thing. Okay, so what happens when you take a statin is it lowers all LDL. So if you have oxidized LDL, it will lower that oxidized LDL, but it does it at the cost of lowering all of your cholesterol. So so it does. So clinically speaking, and in terms of the clinical trial literature, the only validated outcome measure for statin use is the reduction in cardiovascular outcomes in individuals with high CRP. That's it. Okay, so if you have high CRP, then statins have a benefit clinically. If you have low CRP, there is no clinical benefit shown in any of these big, large trials. And a big New England Journal of Medicine paper came out showing exactly that. So statins are only clinically useful in people with high CRP. The question is, well, is statin the best way to lower your CRP levels? Because you say, well, if statins improve my health benefit only if I have high CRP, well, what if I lower CRP by some other mechanism? So if I can, is statins the only way I can lower CRP levels? Which of course is a ridiculous statement. That's not, you don't take a statin to lower CRP. And so that's kind of where the trickery comes in, right? We design trials for specific purposes. And anyway, so that's the whole statin story. So the point is what statins are, they're basically mitochondrial toxins. They block the intracellular manufacture of cholesterol, And since your cells can't make their own cholesterol, it forces the cells to take cholesterol in from the blood supply. So it upregulates the LDL receptor. And so now all of a sudden your cells have to pull in this LDL. So what it's doing, fundamentally what statins do is they suck LDL out of your blood. That's what they do. They get all the cells of your body. So you know what? There's oxidized LDL out there. Why don't I get all the cells of the body to suck up LDL and digest it? And if it digests all this LDL, it's going to digest the oxidized LDL with it. And right. if I get rid of this oxidized LDL by sucking it into all of our cells in the membrane, I'm going to reduce the amount of oxidized LDL available for endothelial infiltration. Which,
right,
it's true. It's just that the question is at what cost, right? And then you know muscle myopathy issues and other issues that you have, and so on.
Well, let's flip over to Alzheimer's a little bit, because now I think that the audience understands plasmallogens and their role. Can you talk a little bit about some of the studies that you talked about in the book? Because I think that's real important.
Well, Alzheimer's is another one of those things that we mistake the library definition with the functional definition. Okay, so Alzheimer's originally, when Alzheimer's discovered it, was called pre-senile dementia, right? It was a woman who had dementia, did a postmortem analysis, found neurofibular tangles and amyloid plaques in the brain. Right. And that turned into be called Alzheimer's pathology. Okay, so it was only considered pre-senile dementia. It's like and so senile dementia was still considered to be an atherosclerotic outcome for many, many years. It wasn't until the 1960s or so that they started looking at this and saying, hey, some of these elderly people with senile dementia also had these Alzheimer's pathologies in the brain. And so then they started labeling it called senile dementia of the Alzheimer's type. Okay, so dementia is a clinically defined outcome. Someone has reduced cognitive functioning and they have a functional deficit in their living environment, right? And the doctor's saying, what's causing this? But when they look at this, so you can have Lewy body dementia, you can have, concussion, white matter, vascular dementia. There's many different types of dementias. The Alzheimer's type has, and remember, we're talking labels here. Okay, there's a dementia person, and we're trying to say, where do I file this person in the library of dementias? And I file this person based upon, is there amyloid plaques or neurofibular tangles? There never was any evidence in humans that these pathologies were actually causing the dementia. They were just measurements, okay?
Right.
And so amyloid plaques and neurofibular tangles are actually not involved in the cholinergic nerve transmission pathway that is responsible for reduced cognitive functioning in humans, okay, which is very well documented. So Alzheimer's is a pathological diagnosis, not a functional diagnosis. It's the presence of neurofibular tangles or amyloid plaques in the brain. Dementia is a functional assessment, whether or not someone has cognitive functioning or not. Cognitive functioning is absolutely unambiguously related to cholinergic neuron function, cholinergic neuron shrinkage. And so the question is, and that is actually a plasmallogen-mediated problem. It's a membrane-mediated problem, okay? And so Breaking Alzheimer's walks you through the actual science of what dementia really means. And then it also says, clearly amyloid is not good for you, right? You shouldn't have amyloid in your brain. That's not a good thing. Neurofibular tangles are not good for you. You shouldn't have that in the brain either. The real question is where are those pathologies coming from? Why are they there? Okay, and amyloid forms because of so the plasmallogen deficiency creates the amyloid deposition because it changes amyloid precursor protein metabolism. So it's not the other way around. And then neurofibular tangles is a totally different situation. This is the homocysteine pathway. So people with methyltransferase, they want to get their homocysteine levels low. So the neurofibular tangle component of Alzheimer's is from methyltransferase deficiencies.
Okay.
Which happens from inflammation, happens because of other things. So, and those two pathologies don't always happen at the same time. You have people with amyloid with no tangles. and you have people with tangles with no amyloid. And the amyloid and the tangles, they occur in different parts of the human brain at the beginning. So they're not really, they're not biochemically linked to each other. Okay. And so that's kind of where I walk people through that concept of that through the process. And so then when you restore mental health or Alzheimer's, preventing Alzheimer's is really restoring. You want to make sure your methyltransferase system is up, which is why I harp on the B vitamins and methyl donors. But creatine is creatine and phosphatidylcholine in your diet is so critical for maintaining that. And then the membrane structure with plasmallogens is the other core component. And that's obviously the big hammer in terms of longevity and cognitive health. So anyway, so I walk through all that in detail. And then I want to tell people why it is the way it is and the amount of clinical data that supports that outcome. And then we test people.
So in your book, you mentioned the fact that there's a tremendous amount of people that have no cognitive impairment that do have amyloid deposition or tangles. And so all these billions of dollars that have been spent over the last 20, 25 years, it seems to me like they've just been barking up the wrong tree. They want to get rid of these things that are maybe there but not causative. There was a new drug just approved by the FDA, Leqembi, this week that is supposed to attack. I haven't really read much about it yet, but supposedly it attacks the tangles or the beta amyloid. I don't know which one, but I think it was the tau proteins. But long story short, are we barking up the wrong tree with all of these drugs, which none of them work? I mean,
absolutely.
I mean, it's just amazing how, medicine gets in these ruts, and then no one picks up their head to look at that furrow and see, well, what's going on outside of this little track that I've been in.
Yeah, one of the problems we have is that technology drives the research versus research driving the technology. And so people study amyloid. Okay, understanding amyloid is a valid research endeavor. We should understand it. And we know a lot about it. Okay, but then what happens then if you want to develop a drug or a trial, and your goal is to find something that you can measure, and then that you can quantitatively link A and B. Okay, right. So amyloid. Okay, I can measure amyloid, and if I can lower it, I can show lowering it. Can I associate this with? So this is what happened with cholesterol. So they're trying to redo the cholesterol statin situation with amyloid, right? Mm-hmm. So cholesterol is not the problem with cardiovascular disease at all. It's oxidized LDL and inflammatory sequelae. It happens afterward. So, but the system is designed to validate that kind of work, right? And also in terms of the intellectual property and the investment it takes, you need to be able to do something that you can protect, right? So natural supplements, natural ingredients for, like, your body is natural. Like you're made of stuff in the environment. We're you're not made of drugs. You're made of actual natural occurring material, biochemical intermediates. You're like a brewery, right? We're brewing beer and wine with. But the problem is, how do you protect it in such a way that you can put hundreds of millions of dollars in investment into a program, right? Right. Plasmallogens, and how do you get new stuff later on? So if I can develop 100 different statins, if I want to blow off the HMG-CoA protein, okay, for a statin, it's not just one options. I have thousands of options, and then I can argue, well, this new statin is a little bit better than the old statin, and I can get a patent on it, and I can get 20 years of exclusivity. And if I have some grandfather program in here, then I can justify the expense to get it out of the system. Mm-hmm. The problem with B12, okay, or creatine, or your homocysteine lowering, methyl B12, methylfolate, trimethylglycine, that kind of stuff, is there's trials that are done, but they're not done. They don't incorporate that into medical care because the medical system isn't designed for that. And the other problem is that if someone does a $100 million trial on betaine, well, you can trimethylglycine, right? You can, I'm just using it as an example. That's not,
Right.
I'm not saying that's the treatment, but anyone down the street can buy it from any other supplier you want, right? So you can't recoup the investment in it. So that's one of the challenges with the whole system. These natural molecules, you can't improve upon plasmalogen. You can't, after the patent expires, you can't improve upon it. It is what it is, right? And that's what, and in this NAD field is a good example of it. I hope I don't step on anyone's toes here, but good old-fashioned niacin elevates NAD levels just as good as anything else. And it's like pennies a pill. It has some flushing aspects of it and all that kind of stuff. But so people are we're kind of forced into creating gimmicks to protect the intellectual property, protect your marketing rights for certain things, and and it's just the way it is. It's just unfortunately. So that's why for what we're doing at Prodrome and the Dr. Goodenow Research Institute is really kind of taking a step back and saying, I had to kind of destroy all my patent technology and say, you know what, we have to redesign all of this because this doesn't work for longevity research anymore. We need to focus on service and focus on solutions that can be used for hundreds of years, not just during the patent cycle. And because once your patent expires, if you don't have a new product, okay, anyone, right? And so it's this rat wheel, right? It's okay, I got a new patent, I got 20 years to make some money on it, roughly 10 probably because it took me that long to get it out there. But I have to get the new one out before that one's out. So I'm on this constant rat wheel of the next patent, the next patent, the next patent, the next patent. I have to have a continual stream of new stuff, or I can't sustain my company. I can't sustain this program. And that's okay for short term. That interest. And again, problem is that the public industry has not taken advantage of all this technologies off the patent. Once the patent is expired, it's a public good. We really need to be maximizing the benefit from these technologies because there is a lot of really good patented, there's a lot of smart scientists out there, a lot of really good investment, a lot of really good science. That's the sad thing about this is that there are so many people who have done just amazing research, but they can't implement it. There's no mechanism for them to get it into routine care. And so that's kind of what my passion is right now, is saying, stepping back a little bit and say, we have to really start seriously thinking about creating a parallel health system for longevity. It's a different model. And you can't, there's some square pegs that you just can't fit into round holes. You just, that's unfortunately, right? And sometimes you can't expect them to, right? And the other part is, I like to say, like Robert Frost, that good fences make good neighbors, right? It's actually, we want a powerful acute care system. Okay, we want that.
Right.
Okay, we don't want that diluted by a bunch of people trying to do chronic care with acute care medicine. That actually distracts from its value. And likewise, in the chronic care longevity space, trying to get all these drugs for longevity research, I think is, trying to label aging as a disease. I think it's the wrong way to go, because I think you're trying to take the current pharmaceutical mindset, and they're thinking, oh my goodness, aging. This is new disease to exploit. Right. And so if I can develop drugs for aging, it's not the right fit.
Right.
So I hope I haven't offended a whole bunch of people with that. But philosophically, I think it's a challenge, I think, for people.
We're actually equal opportunity offenders. We try to offend because really, if you think about it, Dan, if you're not out there and putting it all on the table and challenging people and that type of thing, then you're really not looking to optimize whatever it is you're trying to optimize. And so I kind of pride myself and my colleagues that I hang around with being very open-minded, because, you don't ever learn anything when you've shut everything down to your little, paradigm.
Science is the art of failure. Okay, the whole purpose of science is to fail.
Right.
Okay, our job is to break stuff. Okay, and seriously, the job of a scientist is to break things. Okay, we're not here to prove anything right. We're here to try to prove as many things wrong as possible. That's what a hypothesis is about.
Right.
Okay, we have a hypothesis, and now I lay it out there and say, okay, prove me wrong. Okay, break this thing down. Find out where I'm wrong on this thing, because you can never prove anything right. Okay, all you can do is you can prove something wrong. And so the amyloid hypothesis, the tau hypothesis, these things have been proven wrong and wrong and wrong and wrong again. And you're supposed to give up on a hypothesis once it's been proven wrong. Okay, we're not supposed to get emotionally attached to our hypotheses. And science has become personal. It's become, and people, they get attached to their philosophies, and they don't realize that your job is not to do that. Your job is to break it. And it's only as good for as long as someone can't break it. Okay, right. And that's the point of science. And then that's how you get better and better at it, right? That's how you get better brakes in your car. Okay, you put brakes on, and you got brake pads on it, and you're saying, how long can I run these brake pads before they fail? Okay, your job is to break it. Okay, and then you say, okay, now I'm going to get a new pair of brake pads, and this new pair, I'm going to see how long I can get them to work before they break. And it's through this constant breaking of things that things get stronger and stronger and stronger. And I think we forget that that's our role, is to critically look at things. And, obviously, because it's if you don't destroy, if you don't break negative or false hypotheses, you're stuck with them. Okay, It's mental autophagy. Okay, it's like having dead cells around, right? Like if you don't get rid of the dead ideas, you don't have room for the good ideas. And I think we, because there's so much personal interest, there's financial interest, there's, people have jobs. So it's always a bit sensitive, right? There's real life situations involved, and people are people, right? Scientists are still humans. They have their own, desires and egos and things like that. So, but yeah, I think that's one of the challenges as we go forward, is this being comfortable with failure and embracing it and saying, you know what, if I'm not failing, I'm not trying hard enough.
Well, and that's the nice thing about getting things out, having other people test your scientific method or what you've found. And, they may not be able to say your hypothesis is absolutely correct, but they can certainly say, well, we couldn't disrupt it. We couldn't, make it, so that it's not a valid hypothesis. So I think that's very good. One of the things that I wanted to touch on peripheral neuropathy a little bit. I know we're kind of running out of time a little bit. But if you can touch a little bit on peripheral neuropathy, because that's one of the focus that we have. And I would then like to go into your prodrome testing and just cover that just a little bit, because if you can measure it, you can at least address it, if not many times improve it or correct it. So I was very fascinated with your testing, and I want the audience to be able to see that. So if you want to touch a little bit on the peripheral neuropathy component, because every patient that I've seen with peripheral neuropathy, and these are very complex patients, and the more you get into peripheral neuropathy, the more you realize there's no one bullet. I wish there was. But these are complex and difficult cases. And really what it comes down to is, there might be a peripheral nerve entrapment or a hurt nerve. I mean, peripheral neuropathy it's a horrible term because it just means something's wrong with the nerve outside the CNS. It doesn't tell you if you've got carpal tunnel syndrome or you've got, some type of diabetic peripheral neuropathy or something like that. But the point is that there are some commonalities here that we see. One is that, usually the core metabolism is very poor in these folks. Obviously, diabetic peripheral neuropathy accounts for maybe about half of the cases. But there's always an inflammatory component. These people are, so touch on that a little bit.
So you can think of peripheral neuropathy as basically the neuromuscular version of autism. Okay, so it's a combination of impaired myelination and inflammation. Okay, so sometimes it's better to think of this in terms of brain myelination. Okay, so imagine you have a big busy room and there are 10 conversations going on, right? But the brain myelination, so we're born with very little myelination, and the myelination gets developed both in the brain and in the periphery over time. But when you scan the room, for example, when you tune into one conversation and then you skip and you go to the next conversation and you skip, okay, a big part of neurology is actually detuning out signals that you don't want. Mm-hmm. Okay, so your ability to switch from one conversation to another in a busy room, that's all related to myelination. Okay, it's the ability to actually have a signal directed to one thing. Okay, so then that's the bigger component of it. And then, okay, so you have a group of 10 people talking, right? And now you're listening to that conversation of 10 people. And all of a sudden, one person in that group of 10 starts yelling. Now, if you have a strong myelination, okay, you can identify that one person who's yelling out of the other 9, out of the 10.
Right.
But what happens when you have impaired myelination or inflammation, more and more yelling going on, you can't tell who's yelling. And all of a sudden, you have 10 people yelling at you, not one, because the yelling of one spreads to all 10. Okay, so that spreading part is like an inflammatory component. So when you talk about peripheral neuropathy, what you're dealing with is the fact is that the clarity of the neurological signal, okay, has been impaired. Okay, the precision of the neurological signal has been spread out. And then the inflammatory component of it. So that's why improving the myelination, like the Schwann cell myelination. So we see a lot, like with the omega-9 plasmallogens, dramatic reductions in peripheral neuropathy. So the combination of adding, you need to reduce the inflammation, because the inflammation itself is toxic, right? It's creating the macrophage. It creates glutamate. Okay. Mm-hmm. Purpose of inflammation is to create glutamate excitotoxicity, but it also creates cysteine starvation. So when you're dealing with peripheral neuropathy, you want to do, well, 3 things in total. You want to look at making sure the membrane myelination can be maintained. So cholesterol, phosphatidylcholine, plasmallogens. Okay, especially the omega-9 plasmallogens. Those are the ones that are for the white matter sheath. You want to restore that, because it's the oxidized membranes that stimulate further macrophage infiltration. Okay, the macrophage, the immune system is attracted to a peroxidated membrane. That when a membrane gets peroxidated, it's a signal to the immune system that this cell is near death, and I better go there and deliver the final death blow. So you want to physically fill that up. Then, because if you get rid of the inflammatory trigger, the inflammation will go away. And if you can see that on MRI, if you look at the sequential MRI scans of multiple sclerosis, you exactly see that with the myelination and the remyelination occurring. You can track it with the macrophage infiltrations. So then, why you're dealing with there is mitochondrial insufficiency. So type 2 diabetes is critically mitochondrial toxicity, because glutamate and glucose get co-transported into your cells. So good old-fashioned N-acetylcysteine, carnitine, CoQ10, your basic B vitamins, you need to make sure that the mitochondrial capacity is there. And then the final one is the methyltransferase, because that choline, like you talk about, you can measure phosphatidylcholine in the blood, but there are certain things that happen in situ, right? Like, so when we look at blood work, we can get a generalized state of equilibrium of the body, right? And it's very powerful. But there's certain things that have to happen in situ. Like, and a lot of that membrane building is methyltransferase related. So you definitely want to make sure their homocysteine levels are in that 8 to 10 range. Make sure that, the trimethylglycine, B12, methylfolate, and then the creatine. And so if you can start reducing the inflammation, a big deal of reducing the inflammation. Even the curcuminoids are really good for that, and especially the curcuminoid number 3, like BDMC. You want to reduce that inflammation, but simultaneously you have to remove the trigger, and that's what causes diabetic neuropathy in the first place, right? Diabetic neuropathy, the only way you get type 2 diabetes is glycolytic insufficiencies. Okay, that's the definition of type 2 diabetes. And so skeletal muscle mass. So if you can improve resistance training, you get that. As we get older, so a lot of these diseases that we get are associated with reduced skeletal muscle mass. It's you have two persons in a three-legged race biochemically. You have the fatty acid metabolism part, you have the glucose metabolism part, right? The fatty acid metabolism is your skeletal muscles in your heart. The glucose metabolism is in all cells, right? But as you get older, when that partner in the three-legged race, which is your skeletal muscle, when that skeletal muscle starts reducing its fatty acid metabolism rates, okay, all of a sudden your cells have they've lost their capacity for glucose, because so it's saying, hey, I can't take any more, stay out, right? So when glucose levels go up in your blood, that's because your cells are telling the system, I can't process this glucose.
Right.
So taking insulin just to shove it into your cells, so you're going to take this glucose and you're going to like it, okay, it doesn't make a whole lot of sense. You have to increase the intracellular glycolytic capacity, right? And skeletal muscle mass is a huge, huge thing that's associated with this thing going forward. And as you increase your skeletal muscle mass, it's like creating a whole bunch of little livers for the person. All of a sudden, it cleans up so much. It starts cleaning up their blood supply, and all of a sudden now, your cells have room for the glucose, and they say, okay, now I can take this glucose in because I'm processing these fatty acids again. And so whenever you look at these triglycerides, they're fasting triglycerides, get them under 100. When the fasting triglycerides get over 100, you are biochemically either your peroxisomal or your mitochondrial function is not working properly. And so these are very simple biomarkers, right? And they mean something. They have a meaning. And so that's so for diabetic neuropathy, those are the three big things: is methyltransferase function, mitochondrial function, and membrane structure. If you put those three things in place, the inflammation will subside and the neuropathy will gradually subside. And then, of course, there's the recovery phase, right? Some of those connections have to get remade and reinforced, depending on how long it's been going on, right? And so, but yeah, so that's the long story about diabetic neuropathy.
Wow, we could spend days on that.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.